28-year-old female with off and on foul discharge from left ear for last 2 years. Okay, so this is HRCT temporal bone. There is appreciated a soft tissue density area which is involving the epitympanum and of the middle ear. There is associated eroded scutum, and the middle ear bones are displaced. The roof of the middle epitympanum appears intact.
So what is your differential diagnosis?
Sir, this is cholesteatoma.
Yeah, correct answer.
Yeah. And other okay.
No, I think your description is spot on, and it is pars flaccida cholesteatoma, and it is acquired type of cholesteatoma. Acquired types are almost 98%. And basically, in three things you want to see in cholesteatomas. One is soft tissue attenuation material, as we see in this epitympanum area. Second thing is the mass effect. Like you can see that this soft tissue attenuation lesion is causing mass effect and causing scalloping of the bone and eroding the ossicle. So third thing is erosion. And you can see that erosion of the scutum is there, as you mentioned, erosion of the ossicles is there, middle ear ossicles is there. So it's definitely sparse flaccida cholesteatoma. And it starts in the Prusak space. Prusak space is basically a lateral epitympanic recess. It is between the scutum and the malleus, and it is in the epitympanum. So a Prusak space is a place where the pars flaccida cholesteatoma starts. And this treatment is basically surgery. Surgery is usually with and without mastectomy and ossicular reconstruction.
Okay, thank you, sir.
A 70-year-old female with recurrent left parotid swelling for last 3 years. This is the CT with contrast at the level of the axial image at the level of the neck, showing the both parotid glands, in which I can appreciate that the left-sided parotid gland shows hypodense lesion, which is involving almost whole of the parotid gland.
That is a vein.
Okay, sir.
So what do you think about the size of the parotid gland or the left side? Is it normal or abnormal?
Sir, it's smaller in size.
Yeah, it's atrophic.
Atrophic is smaller in size as compared to the contralateral side.
Okay, so what else do you see in this image? Just having
there
the
is
background.
Enlargement of the vein.
Vein is fine. Vein can be enlarged.
Okay.
Anything else you can see that can cause chronic inflammation of the parotid gland?
Sir, a calcific density is appreciated.
Yes.
Could be the parotid, which could be the stone in the parotid duct causing the atrophy of the gland.
So what is the name of this duct?
Sir, sorry, sir, I can't remember. Duct of
Tenson's duct. So you can see the dilation of the duct proximal to this stone, and if you see a bone window here, you can better appreciate this. This is calcific density within this distal Tenson's duct.
Yes,
there is proximal dilation of this duct, and then there is atrophy of the left parotid gland. So this is going on for a while for this patient. So that's why patient had recurrent episodes of parotitis, and then later on develop into chronic inflammation and chronic atrophy.
Yes, sir.
So this is a case of cytolithiasis. And basically, the cellulitis is more common in submandibular ducts because the viscosity of the submandibular gland secretions is more than the parotid gland secretions. And also
Yes,
the path of the parotid duct is also upwards in the floor of mouth. So 80 to 90% of the stones are usually present in the parotid gland duct, the submandibular gland duct.
yes, sir.
But this is a case of parotid duct, Stenson's duct calculus with atrophy of the left parotid gland. Thank you. Nice description.
30-year-old female with limited mouth opening with left facial swelling for 2 weeks. Okay, I'm provided with OPG. Here I can appreciate a large, well-defined, lucent lesion identified within the body of the mandible. It is arising from the root of the last, I think it's molar tooth. I do not appreciate any calcification or septation within this lucency. Moreover, when I look at other bones, there is no other lucency identified. Other lucency identified within the mandible. Maxillary sinus and rest of the structures appears unremarkable. So, concluding my findings, I'm looking at a lucent lesion, which is arising from the root of the molar tooth. And
what is the next step? What is the next step? What should we do next?
I think to confirm my findings, I think it's a very apical cyst. So I would like to know the history of the patient.
Yeah, that is very good. History is provided.
If there has been any dental extraction performed previously or not.
No tooth extraction. Would you like to have any cross-section imaging like CT or MRI?
Yes, I would like to see the CT of the patient.
Okay.
Okay. So
recording in progress.
These limited CT sagittal and axial images demonstrate a large expansile lesion with the root of the tooth. The lesion is surrounding the root of the tooth. Moreover, no internal calcification or calcification identified. No definite erosion appreciated. Mild adjacent or expansion of the muscle appreciated. However, no fat strandings seen.
Okay. I think your description is very good. And I think you also concluded with slightly cystic lesion in the mandible. So differential includes periapical cyst, as you mentioned. There are other differentials we can talk about. Dentigerous cyst is one of the differentials, but it is usually at the cemento-enamel junction in uninterrupted tooth. Radicular cyst is another differential. Maybe this can be a radicular cyst because it is in the periapical region. Ameloblastoma can be multilocular, more expansile and soap bubble lesions. They can be aggressive and it can be a simple bone cyst. And usually in a young patients, odontogenic keratocyst is the first differential in this particular case because the location is very classic. It is usually at the back of at the angle of the mandible usually, and they are along the length of the mandible. So they grow along the length of the mandible, and they are along the tooth and the dental lamina, and they are not associated with infection because radicular cysts are usually associated with sometimes infection or periapical abscesses. So these are the differential for a cystic lesion in a mandible. And you have described nicely on the radiograph, OPG, and also in CT scan. Thank you very much.
Case number 4, 74-year-old male with right-sided sore of mouth swelling for 3 months. I have been provided with the multiple and multi-sequential images of the MRI base of the skull and orbit at the level of the orbit. Yeah, I can appreciate that there is a well-defined heterogeneous abnormal signal intensity area is noted within the right sublingual area, and it is appearing hypo-intense on T1 and appearing hyper-intense on T2 fat set, and it is not showing any restriction on DWI, and it is showing.
This is the ADC map. It is showing hypointense. Sorry to interrupt. This is the ADC map. Third sequence is ADC map, and it is showing hypointense signal.
Okay.
Suggesting diffusion restriction.
Then it is ADC facilitation. And slight diffusion restriction is noted in the second image. So and it is showing homogeneous contrast enhancement, and it is well defined lobulated margins and extending up to the angle of the mandible posteriorly, and causing slight midline displacement of the muscle compartment. So as the patient, I forgot the history of the patient. I think it's 3 months. Okay, swelling. So it is most likely, as the patient is of old age and enhancing vision, and so it is most likely squamous cell carcinoma. But however, disease would include, but as it is prolonged history and no prehistory of fever and no acute onset, so I would rule out differential diagnosis of any abscess formation or. So the most likely finding diagnosis is squamous cell carcinoma. I would like to do the staging of the patient with HRCT chest and abdomen.
Okay.
Or any metastasis.
Describe spread case. You concluded that this is a tumor rather than infection, so that is very nice of you. And you described that this is in the floor of mouth, and it is showing diffuse contrast enhancement. So it's not a cyst, because contrast enhanced sequence help you to decide whether you are dealing with a tumor like a mass or you're dealing with a cyst. Because there are many cysts that can happen in the floor of mouth. For example, ranulas or epidermoid cysts, dermoid cysts, or thyroglossal duct cyst. So you rule out all the cysts by saying that this is a demonstrating diffuse contrast enhancement. And also on the ADC map, you're seeing that this is showing diffusion restriction. So it's basically highly cellular tumor, basically you're talking about. So what lives in this area? Like, can you tell, like in this area, particular area, what is the most common organ located in this area?
So as it is, so also so this is the mandibular space region, and
basically you want to say salivary gland, so that's correct. So salivary gland can be in this area, and that will be a sublingual salivary gland.
Yes, sir. Yes, sir.
So and there is no bony erosion by this mass, and basically
it can be adenocarcinoma of the gland.
Yeah, it can be salivary gland tumor. Yeah, that is actually more appropriate diagnosis in this particular case. So this case was biopsied and resected, and it turned out to be salivary gland sublingual adenocarcinoma, poorly differentiated. So that was, and I will just go over quickly the differential diagnosis of lesions within the floor of mouth. So there can be tumors, such as in this case, there can be benign tumors, there can be malignant tumors. Malignant tumor we already talked about. that it can be adenocarcinomas, it can be adenoid cystic carcinoma of the salivary gland or mucoepidermoid carcinomas. Because this is a floor of mouth, so there's no epithelium there, so there will not be squamous cell carcinoma in this particular area. And then other lesions of the floor of mouth are ranulas, epidermoid cystic areas, dermoid cyst. Thyroglossal duct cyst is very common in this area, floor of mouth, and infections. And you rule out infection by saying that there is no fat stranding, there is no abscess formation, no diffusion restriction in the center of the lesion. So infection is out in this case. So thank you very much.
32-year-old female with the right cervical mass for 10 years.
I can describe this case quickly. Is that okay?
Yeah, please.
Okay. So this is a large mass in the right carotid space above the carotid bifurcation. And you can see very nicely that it is playing the internal carotid artery and external carotid artery by this mass. Gigi.
Sorry, sir. I unmute because I think due to the internet problem. Okay, sir. Describe.
So please go ahead.
Okay, sir. This is the vascular mass, which is playing the vessels, also involving the carotid bifurcations, and many collaterals are seen distal to it. The differentials, including in the differential, including the first one is the ganglioma, playing the carotid vessels. Schwannomas होते हैं सर इस तरह, और एक कोई चीज होती है जो हम vessels जो intense upper intense होते हैं.
Yeah, you were about to say that starting with P, para.
जी सर, paraganglioma. Sorry sir.
Yeah. So nicely described case. I will just go over this.
But in the MRI images, it's not playing the carotid vessels. It's confused me whether it's paraganglioma or not.
Basically, this post-contrast, sagittal post-contrast is helping you to differentiate this playing of this vessel. You can see that this vessel is being sprayed by this mass, and this is basically the common carotid artery coming up and this bifurcating into two vessels here. And then it's also, you can see on the axial post-contrast sequence, fat set, that there is an external carotid artery anteriorly and internal carotid artery more posteriorly. And this is a volume rendered image, MIP image that is showing this mass, and it is showing its location in the carotid bifurcation. So as you said, I think this is located in the carotid space, and it's playing the vessels. And it is showing some hyperintense signal on the T2 varied images, and it's showing avid or intense contrast enhancement. So paragangliomas show very avid contrast enhancement. So that is the basic teaching point as compared to schwannomas. Schwannomas usually enhance a little bit delayed, and they don't enhance as much as this one. So paragangliomas very vascular tumors, number one. And number two, they show in the books we see that there has been description of salt and pepper appearance. So we do see that appearance sometimes. Salt is basically hemorrhages on the T1 varied images showing hyperintense signal, and pepper is basically flow voids on the T2 varied images. So we can see some flow voids on this T2 varied images. These are showing vessels in the tumor, and maybe there are some hemorrhages area, and these are showing hyperintense area on the plain T1 varied image. And I'll go through some of the teaching points that differential diagnosis of carotid sheath tumors as schwannoma, as you discussed, and a pseudoaneurysm coming from the carotid artery or enlarged lymph node in the carotid space. So we have to differentiate these from paraganglioma. And other thing is that we can diagnose paragangliomas by having a DOTA PET scan or octreotide scan or MIBG scan, basically. So these are nuclear medicine scans. They are very specific for neuroendocrine tumors such as paragangliomas. And paragangliomas can also occur along the sympathetic chain. So usually we can screen for other paragangliomas along the specific chain by having a PET scan or a octreotide scan. And if these tumors are small and they are asymptomatic, we can simply observe these tumors. If they are enlarged or they are growing in size over the period of time, or if they're causing any neuropathy, then we can excise it. And head and neck surgeons usually ask the neurointerventional person to embolize this tumor before they can go in, because embolization of the ascending pharyngeal artery, that is the major supply of this tumor, can decrease the intraoperative hemorrhage and the surprises during the surgery. So that is a way to go. First embolization by the neurointerventional person and then surgery by the head and neck surgeon. So that is a treatment of a symptomatic paraganglioma in the carotid space.
41-year-old male with left orbital swelling for 5 months. Okay. I can see multiple MRI scans focused on orbits. First one is T1. Second one is T1 with contrast.
Yes,
and and third one is DWI. Fourth one is T2, and fifth one is T1 with contrast.
That's it.
Okay, I can see that. There's a mild proptosis of the left eye. There's a little bit of tilt, but still I can appreciate mild proptosis. There is a abnormal signal intensity lesion in the on the lateral aspect of the globe. It seems to be extra conal lesion, and it is hypointense on T1 and it is significantly, it shows significant enhancement on post-contrast images. DWI shows diffusion restriction, and it is located on superior lateral aspect of the orbit.
So what is a normal anatomical organ in this area?
Lacrimal gland.
Yes. So do you think this tumor is coming from lacrimal gland?
So it appears to be arising from the lacrimal gland.
Okay. So what is your differential diagnosis?
Yes, sir.
What is your differential diagnosis in this case?
Lacrimal gland, so much enhancing mass lesion with restricted diffusion. My first diagnosis would be lymphoma, mucoepidermoid CA. These two.
Yeah. So correct. So it turned out to be carcinoma explomorphic adenoma. So you are correct that this is likely a malignancy or neoplasm. So I will go through the differential diagnosis of lacrimal gland lesions, especially the solid lesions. So these can be divided into inflammatory and neoplastic lesions. Inflammatory includes sarcoidosis, orbital inflammatory pseudotumor is very common, especially for lacrimal glands. Sjogren's syndrome is not very common in our area, and infection is another differential. So this is less likely to be infectious etiology because you can see the fat planes preserved in the interconal fat and extraconal fat. All the fat planes are reserved. There was no fluid collection. There was no fat stranding. And the history was not very acute onset. So among neoplasm, as we suggest, pleomorphic adenomas can happen in lacrimal gland, such as also lymphoma, as you mentioned. Other malignancies include adenoid cystic carcinoma, which is very common in lacrimal gland, adenocarcinomas, and metastasis. I have seen breast cancer metastasis going into the lacrimal gland. So we should not forget metastasis in the differential. And lymphoma is also a very nice differential in this particular case.
It's a 57-year-old female with chronic with CLL, presented with headache, fever, and orbital swelling. So I've been provided CT scan, axial view of the orbit and the sagittal and coronal images. Here I can appreciate there is proptosis of the left orbit, and there is a thickening of the lateral rectus muscle and the extraconal compartment muscles, preseptal area and the are also thickened. There is also mucosal thickening is noted in the ipsilateral ethmoid sinuses, ethmoid sinus, and on the sagittal image, I can appreciate there this thickening and the fat stranding is expanding into the intraorbital area in the extraconal compartment. On the coronal images, I can appreciate there is a large bulge or the swelling and the thickening over the left cheek, and heterogeneous densities are appreciated within it, and there is thickening of the all the muscle compartments in the left orbit.
Differential, please.
And there is erosion of the left orbital bone is also eroded. So it is looking to me an aggressive lesion. It's an aggressive inflammatory lesion. It could be any the left maxillary sinus is also almost completely opacified. So
what would you do next? So what would you do next after this? After looking at this scan, what will you do next?
Sir, I will contrast enhanced CT.
These are contrast enhanced CTs.
Sir, sagittal and the coronal are looking, yes, sir. These are contrast enhanced. It is showing heterogeneous enhancement within the sinuses only, and little bit in the muscles. Sir, it's an inflammatory lesion, most likely. It is not extending.
So do you think this is kind of something emergency? Should we?
Yes, sir. It's is it a tolosa Hunt syndrome, which is an inflammatory reaction and the inflammatory process, and in which the acute pain, and we will refer the patient for immediate management.
Would you like to communicate with the clinician and tell him or her emergently that this patient needs urgent treatment? Yes, I would do. This is basically a case of orbital cellulitis.
Okay, right, sir.
I think you described it very nicely. So no problem. I think you described it very nicely, that there is a lot of swelling in the proptosis in the left orbit, with swelling of the extraorbital muscles. And also there is one thing also you want to appreciate here, that there is posterior tenting of the globe.
Right,
That's telling me that this is kind of some pressure or mass effect on this area. And this, we don't see optic nerve on this CT scan, but there might be stretching of the optic nerve also. So we call it orbital compartment syndrome. So this is basically a case of orbital cellulitis with orbital compartment syndrome. And it's like a surgical emergency, and we need to call the referring clinician emergently that this patient need urgent decompression and surgical antibiotic treatment, intravenous antibiotic treatment. So I'll go to the next slide. You're welcome. So I would like to actually share with you a Chandler's classification system for orbital cellulitis. Stage 1 is inflammatory edema, which is only in the preseptal area. 2 is orbital cellulitis, in which you see edema and fat stranding in the postseptal space. Number 3 is subperiosteal abscess. And stage 4 is orbital abscess, and stage 5 is cavernous sinus thrombosis. So for the reporting purposes, you may use Chandler classification for classification of orbital cellulitis. Cause is acute sinusitis. Most of the time, as we see in this case, there is ethmoid sinusitis. And then the infection can seep through the lamina papyracea, which is a thin bone in the medial wall of the orbit. Other causes of orbital cellulitis can be retained foreign body, trauma, infection from teeth or from lacrimal gland. And orbital compartment syndrome is basically raised intraorbital pressure that may lead to permanent visual impairment if we don't treat it emergently. And treatment is urgent decompression and antibiotic treatment.